Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
All right, fuck you, bitches. This is Kevin with the Transformation Nurse Academy podcast. Welcome. Thank you. I hope you have been enjoying the content lately. The last few episodes, we talked about the adult ESI triage levels and the pediatric ESI triage levels. Now we're going to start on the neurological assessment. So welcome back to the Transformation Nurse Academy podcast. Again, my name is Kevin. Today, we're going to continue with our head-to-toe assessment series as we dive deep into the neurological system, focusing on the head and its critical components. Understanding the anatomy and physiology of the head, the spine, and the central nervous system is very crucial when performing a comprehensive neurological assessment. Again, I created a little ebook that you can download. It's not extensive or fancy or anything, but it's free. You can download it by going to transformationnurseacademy.com. We'll also talk about the Monroe-Kelly doctrine, intracranial pressure, cerebral perfusion pressure, and the mean arterial pressure as well. And again, like I said, you can download the ebook and there's more detail in there about that. So let's start with our first segment, anatomy and physiology. First, let's discuss the anatomy and physiology of the head and the central nervous system. So as you know, our fucking head, our skull, protects the brain. We got 22 bones in our fucking skull. The brain itself is divided into several key areas: the cerebrum, the cerebellum, the brainstem. The cerebrum is responsible for higher brain functions such as thought, action, and sensory processing. So the thing that makes you is your cerebrum. And then the cerebellum coordinates voluntary movements, balance, and posture. So when you're all fucking hunched over and slouching, or you're fucking shoveling your feet and shit, that's your damn cerebellum going to shit. And then the brainstem controls basic life functions like breathing and heart rate and temperature. That's where your hypothalamus and all of that is kept. So if you get hit in the front of the head and you don't become you anymore, but your brainstem is still alive, that means the lights are on, but nobody's home. And that happens quite a bit with trauma to the head. The football players that have issues, sometimes they get knocked in the front of the head. And so their cerebrum is getting all jacked up, but they're still able to function because their brainstem, they haven't got hit in the back of the head by that. So when it comes to the anatomy and physiology, you got to understand where the different parts are of the brain. So that way, when you're performing your head-to-toe assessment, you can understand and know which part of the brain may be affected. Remember, your right side of your brain controls your left side of your body. Your left side of your brain controls your right side of your body. That's why I always fucking joke with people and say, I'm left-handed. I'm the only one in my right mind, and all the rest of you are fucking special needs and shit. So we're going to talk about conditions and diseases also that affect the neurological system. So let's highlight some common neurological conditions that impact the patient as well as your assessment. So epilepsy is a big one, or seizures. Epilepsy is a disorder characterized by recurrent seizures. Assessing a patient with epilepsy involves understanding their seizure history, frequency, duration, triggers, and even their medications. So that's a big one that you want to pay attention to and study on. Parkinson's disease, this progressive disorder affects movement, causes tremor, rigidities. That's the one that Back to the Future, Michael J. Fox has. A couple other high-profile actors have that. So during your assessment, you want to look for motor symptoms and evaluate cognitive changes, mood disorders, and autonomic dysfunctions that could be all related to Parkinson's disease. That's why your history is important when you talk to your patient or the family. There's strokes. You could have a hemorrhagic stroke or an ischemic stroke. A stroke is a medical emergency where blood flow to the brain is interrupted either by a clot or by a burst of a arterial. There's a subdural hematoma. There's epidural hematoma. Subdural hematoma is caused by a venous bleed. It's usually caused by the tearing of the bridging veins. It's related to old people, geriatrics, alcoholics, people who are on anticoagulants. Hemorrhagic stroke could be related to the tearing of the middle meningeal artery, so that's something you want to pay attention to. If you do have a patient with a suspected stroke, you want to learn how to use the NIH stroke scale to assess the severity and monitor changes in the consciousness and look for the signs of increased ICP. Signs of increased ICP, confusion, nausea, vomiting, altered mental status. Late signs, you'll have what we call Kuchen's response. So Kuchen's response is widening pulse pressure, reflex bradycardia, and hypotension. So some of your patients, if they're herniating, they'll be breathing real fast, or they could be breathing really slow. The temperature could take high effects or low effects. Temperature could go really, really high, could go really, really low. It's important that you understand the late signs and early signs of increased ICP. Multiple sclerosis is an autoimmune disease where the immune system attacks the myelin sheath covering the nerve fibers, your messaging center. So it's called an innervation issue, INNERVATION, innervation issue. Your brain's trying to tell your nerves and your muscles what to do, but because this myelin sheath has been attacked, the signaling, it's almost like you turn on the light and the fucking light flickers because maybe there's a little slice in the wire somewhere and it makes it flicker because there's not good contact. So you want to make sure you pay attention to those kind of patients. You want to assess for their muscle weaknesses, their balance issues, cognitive changes that all come along with multiple sclerosis. Alzheimer's disease, a progressive disorder, causes memory loss and cognitive decline. You want to use tools like the MMSE or the MOCA for assessment. If you don't know what those are, watch this. It's a beautiful thing. So what is the MMSE or MOCA for assessment? The MMSE is a mini mental state examination, and MOCA is a Montreal cognitive assessment, are two commonly used tools for assessing cognitive function. The MMSE, or the mini mental state examination screening tool, assesses for cognitive impairment and to estimate the severity of cognitive impairment. The components include questions that assess orientation, registration, attention, calculation, recall, language, and visual spatial skills. It's almost like part of the damn NIH score scale. The MMSE is scored out of 30 points. See, almost like the fucking stroke scale, with higher scores indicating better cognitive function. Scores of 24 to 30 generally indicate no cognitive impairment. 18 to 23 suggests mild cognitive impairment, and 0 to 17 suggests cognitive impairment. The MOCA, or the Montreal Cognitive Assessment, the purpose of it is designed to detect mild cognitive impairment, which might be missed by the MMSE. It is often used in settings where early detection of cognitive changes is crucial, like the fucking emergency room. It includes tasks that assess attention, concentration, executive functions, memory, language, visual-constructual skills, conceptual thinking, calculations, or orientation. Again, it's scored out of 30 points, and a score of 26 or above is considered normal. The test is more sensitive than the MMSE. So both tests are valuable tools that you can use. And if you don't know them, just download them. And I'm sure that you can get free resources somewhere for these tools and stuff. So when you are thinking about your assessment, so not only do you got to think about the different diseases that your clients have, what about the medications that they may be taking, or the medications that they may be taking that can also affect the neurological function? So let's talk about some of these medications and understanding these medications and their side effects that could affect you. So like if somebody does have epilepsy, phenytoin and valproate are used to control seizures, and you want to monitor for side effects like drowsiness or cognitive impairment. So even though they have epilepsy or seizures, some of these medications that they're taking can affect their drowsiness and their cognitive impairment. Anti-Parkinson drugs like levodopa or carbidopa help managing Parkinson's syndromes, but they can also affect motor function changes and mood swings. Other drugs like antidepressants like SSRIs, fluoxetine, and then SNRIs like venlafaxine can affect mood and cognitive function. We get a lot of patients that come in, like elderly patients, the geriatrics come in, they have urinary tract infections and they're altered, and people say all the time, that's not my damn mama. Some mothers are very sweet and some are fucking bitches. If your mother's sweet and she's acting like a bitch, that's not normal. So is it the drugs? Is it a stroke? Is it some other kind of neurological condition that's causing it? Is it electrolyte imbalance? Those are the things that you have to do as a nurse to figure that shit out. Antipsychotics and corticosteroids, they're used for various neurological conditions, but can have significant side effects like motor function changes and mood disturbances. So these are things that you want to pay attention to when you're assessing your patient. All right, so let's discuss the head assessment. So you want to start with the scalp and the hair. You know, you want to physically put your fucking hands on people. You want to check and see if they got lice. You want to check and see if they got bumps, nodules. You want to see if there are any fractures or depressions or lacerations, anything like that. Lumps, infestations, look for lesions. You want to feel for the skull, check for the shape, the size, the symmetry, palpate for tenderness, deformities. And then on the face, same thing. You want to inspect for symmetry, color, texture. You want to palpate the sinuses to see if they're tender. You want to check the pupil size, get a light and check for the reaction. Are they equal, round, reacted to light? PERRL. Pupils are equal, round, reacted to light. And then you want to check for visual acuity. Can you see out here? Can you see out here? Can you read the fucking Snellen chart? And then you want to inspect the ears. You want to inspect for lacerations, lesions, drainage. If there's fluid coming out the nose, it's called rhinorrhea. There's fluid coming out of the ears, it's called otorrhea. You just have to determine what kind of fluid is coming out. Is it CSF or is it fucking pus? Is it, purulent drainage? You know, what the fuck is it? Finally, you want to inspect the nose, inspect the symmetry, see if there's any discharge, palpate for patency and the sinus tenderness. Have them open their mouth, look and see if they can smile, see if they can lick their lips, you know, inspect their lips, their teeth, their gums, their throat. And you want to make sure you do a swallow study and see if they have a gag reflex, if they can swallow on command, see if they have any choking or coughing. Older people, geriatric patients, which a lot of our patients, they have decreased musculature of the oral pharynx. You want to check all of that shit. And then once you begin your neurological assessment, you want to make sure you start with the mental status. Evaluate the level of consciousness and the cognitive function like memory and attention. You can use the Glasgow Coma Scale. The Glasgow Coma Scale covers verbal, verbal, and motor. A score of 3 indicates severe brain injury, while a score of 15 indicates mild. Probably nothing, but are their eyes open? Can they close their eyes? Can they squint their eyes? Can they follow your commands and move around? If they can't move their eyes certain ways, if they're not equal, you know, their cranial nerves may be affected. Can they smile for you? If they can't smile correctly and symmetrically, then maybe there's some nerve damage there for whatever reason. Do they know where they're at? Do they know who they are? Time, person, place, and things like that. What is the normal GCS? So the normal GCS is 15. Level of consciousness, alert, orient to time, person, and place. Cognitive functions, memory, attention, language. You know, the Glasgow Coma Scale, eye opening. 4 means spontaneous, means they can open it by themselves. 3 means to speech. 2 means to pain. And then no response at all is a fucking 1. Verbal response are the alert and orient times 3. That's a 5. If they're confused, that's a 4. If they got inappropriate words, meaning they're fucking just making gibberish up. The fucking sky's blue and I don't know fucking why I'm here. That's a 3. If they make incomprehensible sounds, that's a 2. And if they have no response, that's a 1. And in motor response, if they obey your commands, that's a 6. Localizes pain, that's a 5. If they withdraw from pain, that's a 4. If they get abnormal flexion, that's a 3. If that's abnormal extension, that's a 2. And then if they have no fucking response, that's a 1. So you're scoring 3 to 15, but you know, 3 is the worst, 15 is the best. So if you got 13 to 15, you could have a mild brain injury. If you have 9 to 12, that would be constituted as a moderate brain injury, and less than 8 severe. And it's not always true, but you know, most of the time we say if they have a Glasgow vape, you probably should fucking intubate. And then you want to make sure you look at their user stroke scale. So if you have somebody with a suspected stroke, make sure you use the National Institutes of Health's stroke scale, the NIHSS stroke scale. So you want to ask by level of consciousness, you know, how old are you? What's your date of birth? Open your eyes, close your eyes. Do they follow your commands? Do they look at you? What is their best gaze? What is their visual fields? What is their motor function? Can they extend their arms out straight and just fucking sit there like that for 5 to 10 seconds? Do the same with their legs. Lift their legs. Have their legs lifted. Do their legs stay up or do they fucking hit the bed? Do they fall down? If you've never taken the NIHSS stroke scale class, maybe you should. I think every nurse should take that shit. Finger to nose, like the limit taxi. Can you do finger to nose, finger to nose, finger to nose, finger to nose? Can you do sensory? Can you take a little pinprick and poke it on their skin, poke it on their face, see if it's equal? Name some objects, hold up a fucking phone. What the fuck is this? Hold up a fucking pencil. What the fuck is this? Do they have clear speech? Shit, I got dysarthria. I can't even say it. See, look at me. Dysarthria. That's fucking not clarity of speech. Extension and attention. Check for a double simultaneous stimulation. See if they can feel both. So these are things that you want to pay attention to when you're doing your stroke scale class, because all these would tell you if their nerves have been affected. So like there's 12 cranial nerves. There's the olfactory nerve. There's the optic nerve. There's the ocular motor nerve. There's the trochlear nerve, trigeminal nerve, the abducens nerve, the facial nerve, the auditory nerve, the glossopharyngeal nerve, the vagus nerve, the spinal accessory, and the hypoglossus. So the olfactory nerve, that helps with your sense of smell. Your optic nerve, of course, that's your vision. Oculomotor, that's your eye movement. Pupil constriction, that's your CN3. So olfactory CN1, optic CN2. The ocular motor CN3. CN4 is a trochlear, helps you with your eye downward and lateral and stuff. So when you see down and lateral, that's your trochlear nerve. Your trigeminal nerve is your facial sensation and chewing gum and stuff. That's the one that people come in with Bell palsy. Your abductus, that's your CN6, that's your lateral eye movement out to the sides. Your facial expression, CN7, and taste. And then your auditory is CN8, hearing and balance. Your glossopharyngeal nerve, that's your CN9, that's your taste and swallowing. Your vagus nerve, the one that controls your heart rate, when you poke your butthole when your heart rate drops. It also affects your lungs and digestive tract. So that's CN10. And then your CN11 is your spinal accessory, that's your shoulder and neck muscles. And your hypoglossus, that's your tongue movement. So when we have you stick out your fucking tongue and move it side to side, that's what we're fucking messing with you with. All right, so let's get into some things that you can use as a nurse. It's called the Monroe-Kelly's Doctrine, and this will help you with your neurological monitoring. The Monroe-Kelly Doctrine states that the cranial compartment is incompressible. In other words, you got your fucking head, and you hitting the head, your brain's going to swell. And so your brain only has one way to go. If you look through the skull, look through the inferior section of the skull, you see what's called a foramen magnum. It's a hole that your brainstem goes down and your spinal cord comes up and those two meet. Well, if you get hit in the fucking noggin, your brain can only go down because that's the only way it has to go out, and it compresses those 12 cranial nerves. So the cranial compartment is incompressible, and the volume inside the cranium is a fixed volume. This is crucial to understand and managing intracranial pressure. So the normal intracranial pressure is 5 to 15. Elevated ICP can lead to brain herniation. So that's why we want to decrease your ICP. And there's different ways that we're going to talk about decreasing your ICP. If you have a head bleed, we'll try a burr hole, shit like that, or maybe we'll try some osmotic diuretics. Nurses can reposition, they can quieten it. But the Monroe-Kelly Doctrine is CPP, or cerebral perfusion pressure, equals MAP minus ICP, or vice versa. MAP minus ICP equals CPP. So the ICP normal range is 5 to 15. Elevated ICP can lead to brain herniation. Monitoring using invasive or non-invasive methods, and look for symptoms like headache, altered mental status, nausea, vomiting. Those are early signs. Asymmetrical pupillary activities, the Cushing's response, the reflex bradycardia, the hypotension, those are the late signs. Your CPP, or your cerebral perfusion pressure, the normal range is between 60 to 80. It's calculated as a CPP equals MAP minus ICP, and a low ICP can lead to cerebral ischemia. One thing that we used to do in the old trauma ICUs, we'd bag the shit out of you. We would hyperventilate you. Hyperventilation causes you to blow off your CO2, which causes your blood vessels in your brain to vasoconstrict. But what we didn't realize was while we were dropping ICP, your brain wasn't getting very much blood flow, and, it became ischemic. So it's not a common practice anymore. You shouldn't be hyperventilating to decrease ICP. There's other methods and ways that we can try to decrease the ICP and the CPP to manage your patient. This is one of my biggest pet peeves that you don't realize. And when you're coding a patient, somebody's doing high quality CPR and the other person's bagging the shit out of the patient. And so your CPR won't be effective because you're causing the blood vessels in the brain to constrict. Another thing that you're doing is if a physician asks you to hyperoxygenate a patient before I intubate. hyperoxygenate a patient before I intubate. Most nurses reach for the damn ambu bag, hook it up to the oxygen, and start bagging the shit out of your patient. But they didn't ask you to hyperventilate. They asked you to hyperoxygenate. And when you hyperventilate, you're causing the blood vessels in the brain to constrict, and your brain's not getting the oxygen. You're seeing the sats go up on the fucking monitor because your brain is sending a signal to your peripheral tissue saying, hey, motherfucker, you're starving me. Let go of some of that oxygen. And that's what you're seeing on the O2 sat monitor. So you got to understand what they're asking you to do. Hyperoxygenation means putting on a non-rebreather, a nasal cannula, and turn up the fucking flow for 2 to 3 minutes. All right. And then so we talked about the ICP, we talked about the CPP. The mean arterial pressure, or the MAP, the normal range is 50 to 150, and it ensures adequate tissue perfusion. So you want to monitor it manually, or you can do it via line. So there's different ways that we can monitor these as well as treat these. So some non-pharmacological interventions, like I said, elevate the head of the bed. Momentarily, you could try to hyperventilate the patient to reduce CO2 levels, but it's not a permanent fix. You're going to fuck up your patient if you keep doing that. Manage fluids properly. You want to administer fluids judiciously and give the right fucking fluids. All right. So some of the fluids you may want to give are medications through pharmacological interventions would be mannitol, which reduces ICP. Hypertonic solutions like 3% saline, 7% saline, 23% saline help reduce brain swelling. Propofol can decrease metabolic demand. Corticosteroids can reduce cerebral edema as well. So these are things that you can actively do along with the Monroe-Kelly doctrine to help treat your patient effectively to decrease their ICP. So let's talk about some practical applications in patient care. So you want to always obtain a thorough medication history, past medical history using sample, signs and symptoms, allergies, medication, past medical history, last meal, and events leading to what fucking brought your patient into the ED. You want to educate your patients, educate them about their medications and their side effects. If you don't fucking know about that shit, how are they going to know? You're the medical professional. You can't always rely on pharmacy because sometimes pharmacists make mistakes. They're people too. You want to collaborate with the pharmacists and the physicians, but you don't want to rely on them because it's your job to make sure that you know what to do. All right. So let's talk about a couple of case studies that I brought up. So you got a 25-year-old. He's got a traumatic brain injury. He's a 25-year-old male with a head injury from a motor vehicle accident. He has decreased level of consciousness, unequal pupils, and elevated ICP. So what would this be a sign of? Would this be a sign of early ICP findings or late findings? Would it be early finding of a head injury or late finding? Decreased level of consciousness, unequal pupils, and elevated ICP. Those are all classic signs of late signs of increased ICP. You want to elevate the head of the bed. You want to administer mannitol. You want to do continuous ICP monitoring. Or your goals are to decrease the ICP to improve the neurological status. So depending on if you got a head bleed or just swelling, those are things that you want to do. Another case study we could talk about is a stroke. 68-year-old female has a right-sided weakness. So she has a right-sided weakness. That means her stroke is on the left side. She has weakness and slurred speech. You perform the NIHSS stroke scale score of 15. And then you do a CAT scan. And the CAT scan shows an ischemic stroke. So one, how long do you have to treat this lady? So you have to ask, when was the last time she was shown normal? So if it's 3 hours, 4 hours or more, she may not be a candidate for TPA. Now here where we work in the Valley, we moved, now I don't know if this is nationwide, but I can't imagine it's not, but we no longer use TPA. We use a drug called tenecteplase. It's way better than TPA only because you don't have to mix it and wait for it. You can just push it over a few seconds and you're done. But you only have a 3-hour window to administer this stuff. Only physicians and certain physicians, probably neurologists, can override this 3-hour window. If it's more than 3 hours, the damage is kind of done and your patient's kind of fucked now. So with this NIHSS score 15 and this CAT scan that shows an ischemic stroke, you want to administer some kind of clot buster like the RTPA to tenecteplase within that 3-hour window. You're going to do frequent neurological assessments because you want to improve the neurological assessments and you want your NIHSS score to reduce to 5. The lower the score, remember the score goes from 0 to 20 or 0 to 24. I can't remember now, but I think it's 0 to 24. 0 meaning no stroke, 24, you got a really fucked up stroke. So you want to make sure that you pay attention to these things when you're performing your head to toe assessment so that way your patient doesn't have any issues, because otherwise you're going to have poor outcomes and stuff. All right. So we talked about the ICP. We talked about the CPP. We talked about your head to toe assessment. We talked about medications. We talked about practical applications. We talked about a couple of case studies. So, mastering your neurological assessment of the head is a crucial skill for any registered nurse and LVNs as well. We covered the foundation of anatomy and physiology. I didn't go great detail, but it's in the e-guide, in the ebook I have. We covered the spine, the central nervous system. We talked about the Monroe-Kelly doctrine, the ICP, the CPP, and the MAP. We talked about the understanding of these parameters and how they influence the brain function and the patient's outcomes. We discussed the different neurological assessments. We discussed the timeliness of monitoring and intervention. So by integrating this knowledge into your head-to-toe assessment and understanding the details of them into your practice, you can enhance your ability to identify and manage neurological conditions more effectively. Remember, continuous learning and staying up to date on these best practices are a key to providing the highest quality of care. All right, so I hope that you learned a lot. I hope that you use the ebook. Don't be shy to download it. I appreciate everything you've done for us, and keep listening on, all right? All right, bitches. Don't forget, Transformation Nurse Academy podcast. You can download this ebook for free. Hope you listen, motherfuckers. Peace, bitches. Be a fucking excellent nurse, not a shitty nurse. We got too many fucking stories out there with all these fucking shitty nurses. So be an excellent nurse, not just a good nurse. Keep up with your fucking skills, motherfuckers.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.